Hi, and welcome to Chapter 9 on immunodiagnostics. This chapter is sort of one of the necessary evils that we need to go through. It's really not evil. For step 1, because as we know, the types of questions that they like to ask tend to put in some data from lab tests and things like that you need to sort of be able to interpret and understand. Fortunately, if you have a good understanding of the previous chapters, this will go pretty smoothly, but you can anticipate having some of these lab tests within some of the immunology questions. So let's tear this up. We know that serology is an important tool for lots of different diseases, from infections to autoimmune diseases. And it is actually the interaction of the antigen and the antibody that occurs to any given infection, or again, during an autoimmune disorder, that gives us the basis for these tests. We are now going to revisit IgM and IgG. Hopefully you remember everything we went through already regarding IgM and IgG, but IgM is the principal antibody that's made in the primary immune response. So the very first time you come in contact with antigen, the first antibody that you're going to make is IgM. This is replaced a little bit later by IgG. So in your memory response, you are going to predominantly make IgG over IgM. Now, one of the things you need to keep in mind is that, again, it's not black and white. It's not that we only make IgM during the primary response, we only make IgG during the memory response or the secondary response. We can make IgM a little bit in that secondary response, okay? But these are going to be, again, cells that have encountered that antigen, maybe a different epitope, for the first time, okay? So, just a couple of examples here. A patient that has IgM antibodies to the core antigen of hepatitis B virus, we know that we're going to use that to screen recent infections. And that's actually going to be a really important point when you go through the serologic panels for hepatitis B. The reason that this is so important is because we can actually find core antibodies during the window period when the surface antigen and the surface antibody are bound up together in immune complexes. That core antibody being present allows us to more accurately diagnose acute hepatitis B infections. Another important and helpful feature about IgM is that it is really important in diagnosing infections in neonates or fetuses. Again, going back to what we already know, IgM does not cross the placenta. So there are some important things that we can gather from that when we're trying to diagnose infections in either neonates or fetuses. The only way you're going to have, let's say, a fetus that's producing IgM that's specific for any sort of pathogen is if that fetus or neonate was infected with that agent. Again, that IgM is not going to cross the placenta. So a good example is if you had a neonate that was making IgM specific for rubella. There's quite a few things that you could actually say about that, and step 1 loves those rubella questions, okay? So if the neonate is making IgM for rubella, the neonate has an infection. That means that the mother had a primary infection with rubella during pregnancy. That means she had a viral xanthum during pregnancy. That means she was not protected, not vaccinated. So there's a lot of different ways that they tackle those types of questions, but that's going to be a really important point, and it's going to be really helpful for you sort of dissecting some of those questions on step 1. Let's overview in graphic form the difference between the primary and the secondary immune response, really just honing in on the antibody response. If we look at the primary immune response, the first thing I want you to notice is that from the time that the host was challenged with the antigen to the time that you're going to actually be able to detect antibodies has a pretty good lag period. And we know this to be about 10 days to 2 weeks in that period. But you're going to notice that we predominantly make IgM. Eventually, though, As you hopefully recall from previous chapters, class switching will occur, affinity maturation will occur. We will eventually make IgG that's highly specific for that antigen as the immune response sort of tapers down and we eliminate the antigen. Upon secondary challenge, this is an important point, with the same antigen, you can see now the immune system predominates with IgG. You can see that lag period is much shorter, so now going from 1 to 2 weeks to 1 to 2 days. But you can also see that there are some levels of IgM, again, probably to different epitopes on that antigen that weren't recognized the first time. So this is a really important graph. It's going to set us up really nice for serology. You should know, of course, again, that IgM is going to be really important in screening recent infections, particularly in neonates. It's going to be essential, and that we switch over to IgG. Another question they sometimes like to ask regarding this is that you have a pregnant patient who had a known exposure to rubella, but she was making a lot of IgG towards rubella. And then they're going to ask you sort of what that means. Well, that means that she has seen it before, either through vaccine or she actually had the infection. She's making IgG, which crosses the placenta, which means that the fetus is protected. So all of this information is really good. It's going to be really helpful in allowing you to, again, sort of dissect a lot of the questions that they're going to throw at you.
We need to reintroduce some of the original ideas that we had discussed in this lecture series. I'm sure you all recall that our antibodies are broken up into distinct regions. We have the idiotype, and that idiotype is going to be where we have the antigen binding site. Now, the term idio actually stands for unique. Each antibody will bind with great specificity to one and only one antigen. This is a unique event. So again, whenever you see that word idio, don't think idiot, think unique characteristics. So please recall that that area is going to be the antigen binding site. Each antibody is unique, but if we look at the entire population of antibodies, they are going to show extreme diversity because each will be specific for one antigen, but overall they will cover millions, if not billions, of different antigens. We've also gone into a lot of the details about the isotype. The isotype is going to be located in the heavy chain constant regions of the antibodies, and it is going to dictate what the function of our antibody is. And it's really simple. We only have 5 isotypes. So recall, we have IgM, IgD, IgA, IgE, and IgG. We have one last characteristics of antibodies that we need to discuss with you, and this is the allotype. The allotype, notice the part allo in there, is going to refer to our allelic differences that people are going to have in between the same isotype. So what I want you to consider is that the heavy chain gene is always represented by 2 alleles. And I always like to say I got one of my alleles from my ma and one from my pa. And since my parents have unique sequences, those sequences are not going to be the same as, let's say the sequences of Dr. Moscatello. So we will have these subtleties that are going to be distinguishable between one individual and another, even though we all have the same isotypes. So why does this even matter? Well, it matters when you have a patient who is receiving pooled gamma globulins. Why is that? Well, anybody who's receiving gamma globulins is usually sick. They have a tendency to receive multiple transfusions. And what will happen is that over time, they are going to establish their own antibodies against the allelic variations. Again, because my IgG has subtle changes that are seen as non-self. And the result can be that an individual can have a type 1 hypersensitivity against your pooled gamma globulins, or there's another situation where you can even have a type 3 hypersensitivity. And you're going to talk about type 3 hypersensitivities when we get into chapter 12.
All right, Dr. Ali and I just had an argument as to who was covering papain versus pepsin, because we really both feel pretty guilty about even having to discuss this with you. And you can clearly see that I lost the bet. So here we go. Papain versus pepsin. Clinically, are you ever going to use this? No. Are you ever going to need this ever again in your life? No. Where are you going to possibly use it? That's right. Step 1, USMLE. So let's just do it as quickly and painlessly as possible. All right. Papain versus pepsin. These are enzymes that digest antibodies at different spots. What? Yes, different spots. And depending on where the antibody is actually digested, you can wind up with different fragments. And we're going to take a look at those fragments and what possible questions they can ask you from this. So let's start on the left. When an antibody is digested with the enzyme papain, you can see that the resulting antibody fragments give you two separate FAB fragments. You can see that these are no longer bound together, which means that each one of these can still bind to an antigen, but if you only have one binding site, you are unable to agglutinate anything or precipitate anything, and that's going to sort of be the theme that you want to think about, okay? So now let's look at pepsin. Pepsin digests the FC portion of the heavy chain up to that disulfide bond that holds the two FAB fragments together. So you still wind up with a bivalent molecule. Now for USMLE, that means that you could actually still precipitate or agglutinate because you actually still have two binding sites. This is called the FAB prime 2 fragment. And the way that you're going to remember this is, I don't know about you, it's early in the morning as we're doing this, but sometimes these antibodies look a little bit like a martini glass, I'm just saying. So if you can remember that after digestion with pepsin, you could actually have an ice cold glass. We're just going to have our Pepsi Cola in this martini glass because, again, you have these two fragments bound together and you can actually serve a nice cold drink within that leftover fragment. That's how you can remember pepsin, Pepsi. We can have an ice cold glass of Pepsi after digestion with pepsin. After you take this test, I promise you, you can dump this from your memory. Unlike papain and pepsin, the zone of equivalence is actually a really important concept for immunology and clinical diagnostics dealing with immunology. And essentially, what we're going to be doing in the next few slides is taking a look at the interaction between antigen and antibody during different sort of disease states. Now, when we have the equivalent amount of antigen and antibody, we actually form immune complexes. And during that time, we will often refer to that as the zone of equivalence. When the concentration of antigen and antibody are approximately the same, that sort of maximizes the agglutination or precipitation, because these guys tend to fall out of solution within these immune complexes, and this is referred to as the zone of equivalence. This figure shows really well what happens sort of during the course of an infection and sort of highlights why we see that zone of equivalence. So let's sort of take a look. At the beginning of an infection, you are going to have a higher concentration of antigen versus antibody. That should make sense based on everything we've learned thus far. Again, that sort of highlights the importance for IgM early on in the infection because we have antigen in excess. However, when we have an excess of antigen versus antibodies, you can see that we are not going to get a maximal precipitation or potentially a agglutination reaction because the antigen is sort of soaking up all of the binding sites on the antibody. Let's look at the other side of this graph. Toward the end of the infection, we are going to have more antibody than antigen. So we have the antibody excess zone. And again, not really good for maximizing the amount of antigen and antibody within an immune complex. But right in the middle, where we have approximately the same concentration of antigen and antibody, this is where we tend to see immune complexes, and we've referred to this as the zone of equivalence. In the next slides, we're going to sort of really highlight some really important features when we're talking about zone of equivalence, but this is really going to become important when we start taking a look at the hepatitis B serology. So as I mentioned, how can we sort of clinically dissect the importance of the zone of equivalence? The easiest way is for us to take a look at the hepatitis B serology. Early on during the infection, just as we were talking about with any infection, you're going to have antigen excess, and for hepatitis B, this is the surface antigen. So early on, we can find surface antigen in the blood. However, as you start to have approximately the same amount of surface antibody and surface antigen, you start to get immune complexes. Now, clinically, that has some importance because those immune complexes can cause some type 3 hypersensitivity diseases. But it's at that point that we say that the patient is in the window period. And this is equivalent to, you bet, the zone of equivalence. So we can no longer within the window period detect surface antigen or surface antibody, which is why the antibodies to the core antigen are going to be so important for screening recent infections. So, after the window period, we are entering the point where the antibody is in excess, and that's when we will be able to detect antibodies to the surface antigen. This is a good sign if we have acute hepatitis because it is showing finally that we have resolution of the infection and we have not progressed to chronic hepatitis. An important concept when we're looking at serology is just to understand the difference between polyclonal antisera and monoclonal antiserum. Now, one of the things you just need to know is that if we're talking about polyclonal antiserum, this is what you get essentially as a result of just about any type of infection that you may have. Your immune system is going to react to all of the different epitopes on the antigen and produce antiserum that again has multiple different specificities. So the polyclonal antiserum represents all these different clones and specificities of B cells making antibodies to the different epitopes on that antigen. So it's a very heterogeneous mixture of antibodies. So as I said, polyclonal antiserum can be used clinically. We can generate polyclonal antiserum within animals the same way that you would make polyclonal antiserum. So we could inject an animal with a particular antigen, harvest the polyclonal antiserum, and we can actually utilize that for certain diagnostic tests that we're going to be talking about throughout the rest of the chapter. Monoclonal antibodies or monoclonal antiserum is sort of a different story. Now, we wouldn't really expect during any given infection to produce monoclonal antibodies because that suggests that we have one clone of B cells making the same antibody. Now, you can see this in certain malignancies, but Other than that, we really wouldn't expect to see a monoclonal spike in antibodies unless we were looking at something like multiple myeloma. Now, we produce monoclonal antibodies in the laboratory and we use them all the time. And you really don't need to know sort of the mechanism as far as how these antibodies are produced, except for that we take a B cell with the specificity that we're looking for, and we essentially fuse it to a cancer cell or a transformed cell. And that allows it to just continuously produce antibodies with one different specificity. Now, what's really cool about these antibodies is not only can we use them diagnostically, which is sort of cool, but we can also use them to treat certain diseases. A lot of the biologic molecules that you guys are going to be learning about and are exploding right now as we go through this lecture are monoclonal in nature. One of the really neat things that they're doing with these monoclonal antibodies is, even though they may be producing them in cell lines that come from different animals, they can humanize these so that we have less of a reaction to them. So this is sort of a big part of medicine and also a huge part of immunodiagnostics. So this is one of the questions we commonly get when we're teaching this course. And students want to know, really, how do you differentiate what a polyclonal antiserum is versus a monoclonal antibody per se, okay? Polyclonal antiserum, as you can see here, dictated by all the different colored antibodies. Polyclonal, so think multiclonal, they're essentially specific to all different types of antigens, right? If you make an immune response or antiserum against any given pathogen, there's not just one antigen on that pathogen, there are multiple antigens. So for every infection that we get, we develop polyclonal antiserum to that particular infection. Okay, so polyclonal, capable of binding to lots of different antigens. Monoclonal, just one, so one specificity. Okay, now this is not sort of a normal situation. So if you were to find this clinically in someone, it probably suggests if they have a monoclonal spike, maybe they have a multiple myeloma, they have some sort of transformation of a plasma cell that's giving you an antibody that's all specific sort of for the same antigen because that cell has transformed. Where we really use monoclonal antibodies, and it's going to be super important for you guys, is of course as biologics in treatment. And we're using these for all kinds of different things now. We use them for cancer therapy. We have monoclonal antibodies that can be used in treatment for respiratory syncytial virus. We actually have some monoclonal antibodies now that can help eliminate anthrax toxin in patients. So we're really moving forward with these monoclonal antibodies. And again, for you guys, you should be more concerned with monoclonal antibodies when you get into the pharmacology, because in a patient, it's really not sort of the normal situation. The normal situation is going to be to make that polyclonal antiserum.
Clinically, you're going to be using a lot of serological assays. On the USMLE, what they will ask you about these particular tests are some of the characteristics. One of those are going to be, is this particular assay a direct or an indirect serological test? Now, I always try to oversimplify things, so when you're talking about direct serological testing, I just want you to take the word direct and I want you to put an equal sign to antigen. With direct serological testing, you are always looking for an unknown antigen, which means that you have to have in that assay known antiserum, which will contain antibodies that would be able to recognize that antigen if it was present. So again, direct serological testing, I'm looking for my unknown antigen. Typically, serological testings that are direct in nature are qualitative. So you get a positive or negative response versus some other testing which will be more quantitative, such as indirect serological tests. Typically, we're going to use direct testing for screening purposes, so just keep that in mind. Our indirect serological testing is going to assume that you know what the antigen is and you are trying to determine if the patient has been exposed to that antigen and has produced their own antibodies in response. So if we look over here at the figure, again, in this case, indirect, you're trying to determine unknown antibody response. So you will collect the patient's serum, allow the serum to be mixed with a known antigen, and if the antibody is going to bind to the antigen, you can determine that binding by the use of a secondary antibody, and that secondary antibody is typically labeled with a fluorescence tag, a radioactive tag, or in the case of ELISAs, an enzyme-linked tag. Just like we saw with the direct testing, an indirect test can also be qualitative, meaning you get a positive or a negative response. But one of the advantages of indirect testing is that you can also get some quantitative information and determine exactly how much antibody against the antigen is present in the patient's serum. Exploiting the quantitative nature of our indirect assays, we are able to actually generate fairly good antibody titers. Now, a titer is going to be extremely important for a couple of reasons. One is that you can follow the progression of a disease, whether the individual is having an increase in the infectious rate, which is reflected by an increase in antibody titers, or if somebody is recovering from an infection, you would see a drop in the level of antibodies. Another arena that antibody titers are going to be important are going to be when you are managing the disease with different therapies. So these can actually reflect whether or not a therapy is actually working. Maybe the therapy is not working as well as you had hoped. And it also can reflect where you have mutations and resistance arise. So a titer is simply going to take a patient's serum and go through a series of dilutions. And you can determine the titer based on how dilute the serum gets and still has detectable antigen. This figure nicely illustrates what an actual antibody titer test would look like. On the left, we have a series of patients 1 through 8, and each patient's serum is going to be serially diluted from half dilution to a fourth, and again, as you go up, you're going to double the dilution every time. Please note that you always need a positive as well as a negative sample in order to compare the patient's serum to. So if we look here at, let's say, patient 1, the patient 1 is said to have an antibody titer of 128, and that is because you were still able to get a positive result after a serial dilution of 1/128. What about patient 7 here? Well, with patient 7, you actually get more of a qualitative response because the patient does not show any antibody titer at a 50% reduction. So you could say the titer here is less than 2, but obviously the person is showing some sort of symptoms or they would not have been worked up in such a way. So you can have various degrees of titers, as again shown through the other patients in this sample. Indirect serology assays in general are going to be a little more specific than the indirect test. And when you're talking about specificity, what you're looking at is an assay that is going to report much lower levels of false positives. So just some examples of tests that you are going to see clinically. We're going to go through the Coombs test. You also have the ELISA. Everybody loves themselves a little ELISA. And we also have fluorescent antibodies test. Now, these three tests can either be direct in nature or indirect. So you need to be careful when you're reading through the clinical vignette to determine the following. Am I looking for antigen? Meaning it would be what kind of test, Dr. Moscatello?
Direct.
Direct. Or am I looking at antibody production, which would indicate that is an indirect test?